சரியா? Certo.
Good evening. We'll keep on to time and shall we start the sessions today. I'm sure that more and more people will join, but since we are going online, we have to start on time. Today our guest lecturer is, if I can introduce him, he's Dr. Asantha Malaviye. He's a graduate from the University of Colombo, MBBS. Then he obtained his PhD in sexual medicine from University of Oxford, UK. And he has been a guest lecturer all over the world. And some outstanding awards, for example, 10 outstanding young personality award in 2011, and so many guest lectures and presentations both locally and abroad. I myself have listened to him a couple of times. That's how I invited him, and he's going to speak to the topic which we have advertised, rather interesting. Right? So I have told him, knowing how people who do oral health, to touch on the older side of this version. Then let me kindly invite Dr. Asantha Malaviye. One kind reminder to keep your mobile phone switch off or in the silent mode, please. And after his lecture, there will be a short presentation by our sponsors tonight, which will be followed by cocktail and dinner.
Thank you, Dr. Dilip De Silva, for that kind introduction. Often I get invited by people with some ulterior motives, like they sometimes try and get a topic of their interest covered by me. But in this situation, I think they thought he had listened to this topic, and he was thinking about his members of the association. So I think we should give him a round of applause for that. Thinking about your sexuality. I don't know where to pitch, because you all are doctors, and dental doctors who are specialized in the oral cavity, as your president said. So maybe I don't pitch it correct. If I don't communicate in a way that you understand, please raise your hand, and we'll make it a more interactive session rather than just one-way process. What do we understand by sexuality as dental doctors? Is it just about inserting the tab A to slot B, or just sexual activity, or is it more than that? What is sexuality? What do you understand by sexuality? Is it just the sexual intercourse? No, it's actually much broader. It involves the relationship, it involves the mind, it involves all sort of interactions with the society. All these factors influence the sexuality. When I say midlife, what is midlife? Is it the same topic that was in the, yeah, okay. The midlife is the from age of 40 up to 60 or 65. Old age really begins at 65. So when I say beyond, is beyond 65. Midlife is from 40 to 65. It's sexuality, let's talk about sexual activity, not just sexuality. When you look at sexual activity, is it beneficial? Now, all of you are dental surgeons, and you talk about oral hygiene and brushing teeth. Can I ask you all to raise hands, those who brush teeth twice a day? Twice a day, brushing teeth? All of you, great, wonderful. So this question is only for men actually. Can I ask you to raise your hands if you have at least 2 ejaculations a week, not per day, per week? Right, okay, none, I know. So I don't, it's okay, we can do this. We can ask all of you to close your eyes. So only I see the response. Right. Anyway, we'll skip that. But anyway, I'll tell you the benefit of the frequent sexual activity. You know the benefit of brushing teeth twice. First, one important study. I'm not just giving empirical evidence. I'm giving scientific evidence. First study is known as Duke longitudinal study of aging, and they found that the frequency of intercourse a significant predictor of longevity in men. Another Swedish study, which was published in 1981, they found that early cessation of sexual activity to be associated with premature death. This is why I asked whether you have at least 2 ejaculations a week. In this very important study known as Caerphilly, cohort study which was conducted in Wales, Caerphilly, they followed up men aged between 45 and 55 over a period of 10 years. And those who ejaculated at least twice a week had a 50% reduction in cardiac death during this 10-year period. This study did not look at the mode of ejaculation, whether it's masturbation, whether it's the sex with the partner or somebody else. They didn't look for it. And now, after listening to this, don't go and fight with your partners, saying that you don't have enough sex and you are trying to kill me, right? Right? Because for 2 reasons. One is these studies are the observational studies. There is a control group, but no, not exactly. There is no control group, so it's not a case control study, right? We don't know whether the healthy people had more often sex, or whether they lived longer because they had sex often. We don't know. So don't go and make a big fuss about it at home, or take unnecessary sexual risks to have 2 ejaculations. What about ladies? There are a fair amount of ladies. Will that help them as well? Unfortunately not. What is important for ladies is not the frequency, but the quality of sexual activity. If they are sexually satisfied, they live long. This was calculated to equate 4.28 years of life. If they are sexually satisfied, again part of the study, they live 4.28 extra years if they are sexually satisfied. let's look at what the men and women in midlife or beyond think about sexual activity. These are the findings of Global Health Survey, which looked at men and women aged between 55 and 85 years. 65% of women and 87% of men consider sexual activity as an important aspect in their lives. So, vast majority of men and a significant amount of women thought it's very important. Let's look at, people have a lot of anxieties about how often they should have sexual activity. I talked about 2 times, this thing is just one study, but let's look at a real experience, what really happens in the general population. This is a study that was published in New England Journal of Medicine, and they found that the men aged between 40 to 49 years, 93% were sexually active. It's little lower in the females of the same age group, which was 88%. And 57 to 64 age group, 84% of men were sexually active, and 62% in the female group, in the same age group. In the 65 to 74 age group, 67% of men and 40%, only 40%, very less compared to men, were sexually active. 75 to 85 age group, 39% and 17% were sexually active respectively in the male and female groups. So, what do you feel like you can put, you can figure out where you belong to. Vast majority of men are sexually active even at the 7th and 8th decades. But when you look at females, their sexual activity is much less. Comparatively, for the same age groups, there can be several reasons. One could be in a spousal relationship, the female could be younger. And the other reason is the men tend to die early. I hope you all know that 7 to 8 year age life expectancy difference throughout the globe. So the woman without a partner is very likely than a man without a partner. And also the remarriage pattern, especially in the West. The men tend to remarry, but it's often not the case for women. So these factors may have contributed to lower sexual activity in females. When we say sexual activity, yes, some activity, but how often? These are the findings of the same study, but I combined 2 studies, but this is only the study that was published in the New England Journal of Medicine in this slide. So 57 to 64 group, 67% males and 63% females had 3 times sexual activity per month. This is from the men and women who were sexually active, and I'm talking about the frequency, more than 3 times. 65% in the 65 to 74 age group, 65% of men and 64% of females had more than 3 times sexual activity. In the 75 to 85 age group, 55 and 54%. So there is no much of a difference between the age groups and the gender. Those who are sexually active very likely to have sexual activity more than 3 times a month. Now, what type of sexual activity do these mature men and women engage in? Because people tend to think that sexual activity is only for young men and women and not for mature men and women. So, but we found that I showed you the scientific evidence and research data of the sexual activity and how frequently they have sexual activity. But now let's look at how frequent, what sort of sexual activity do they engage in. With advancing age, sex becomes less intense, less frenetic. It is not very, it may not be less, what do you mean, less intense, you get what I mean, but not necessarily less enjoyable. They enjoy, but it's less intense. And they find new ways to stimulate each other. Simple things can give some sexual satisfaction, like reading erotic stories to the other person, the warm massage, and according to one study, in this 57 to 64 age group, 50% had oral sex. And as Dr. Dilip said that you all are experts in the oral cavity, maybe you all are experts in this as well, but I don't need to teach you more techniques of oral sex, but let me give you another perspective to oral sex. Listen to these two birdies. Grandpa, do you still have sex with grandma? Yes, but just oral sex, dear. What is oral sex? I say, you. She says, do. So it's not difficult to have oral sex. If you don't practice oral sex, go on. Keep. It's easy. So easy. Right. So apart from oral sex, what other forms of sexual activity do these men engage in? The more than half of men and quarter of women, whether they had sexual partner or not, acknowledge masturbating. I recently met a couple who were devastated by the fact that she, the lady, has found him masturbating while watching a pornographic movie. So if you know these statistics, you shouldn't be worried about that. So the masturbation is common whether you have a sexual partner or not. And frequency of masturbation declines with age, but less markedly than the coitus. So that the main form of sexual outlet above the above the age of 80 becomes masturbation, because both decline, sexual activity declines, masturbation declines, but at a lesser masturbation rate declines at a lesser rate. So it becomes the predominant sexual outlet after the age of 80. So what are the determinants of sexual activity in the midlife and beyond, or elderly? I like to avoid the word elderly. Main problem for many men and women to continue sexual activity after 40, maybe after 65, is sexual dysfunction and reduction in overall health. As I said before, non-availability of sexual partner can be an issue. And the other factor is the sexual activity in the early adult life. So if you are in that group, have more sexual activity, then the decline will be less. Psychological and socio-cultural and relationship issues. These are very powerful factors in our socio-cultural setting. In our culture, women are expected to look after their children when they are in their 30s and 40s, and then they are even grandchildren than being sexual. And so these cultural factors can have an impact, and lack of privacy, and you have to even if you want to have sexual activity, you don't have adequate privacy because of the sometimes children, then the grandchildren, or extended family. So and also the personality traits. Some personality traits like narcissistic and the schizoid personality traits, they find it difficult to adapt to changes in their with changes that occur with adult age or old age. So I thought I should, these are the common male sexual problems that are found in midlife and beyond. But I thought at least to discuss one of them, the erectile dysfunction, because it's very common, and some knowledge about that is very useful for both men and women. This man, 500 years ago, very correctly said, "Is it not strange that desire should so many years outlive performance?" You know him, William Shakespeare. So let's look at erectile dysfunction. This is the findings of the study known as Massachusetts Male Aging Study. You can see in the 40 age group, about 40% of men have some degree of erectile dysfunction. Out of that, about 8%, 7 to 8% have severe or complete erectile dysfunction. In the 70 age group, about 68% of men have erectile dysfunction. Out of that, about 20% or 18% have severe or complete erectile dysfunction. Isn't this very interesting? This is the best study ever conducted in this field in the world. And at the age of 40, about 40% have erectile dysfunction. And at the age of 70, about 30% of men have normal erectile function. If you look at the other group, when about 70%, to be exact, it's about 68%. 68% have erectile dysfunction, 32% have normal erectile function. Why is this? It's because it's not just the age. Age is the non-modifiable risk factor. We can't change age, but there are so many modifiable risk factors that contribute to erectile dysfunction. So I thought I should cover the modifiable, at least the modifiable risk factors. There are so many, the hormonal, neurological, endocrinological, and psychological factors. But I am talking only about the modifiable risk factors because they are important, and we all can avoid these factors. If you look at the evolution of the humans, when we started or when we invented farming, it became very efficient than hunting. It was actually more than 50 times more efficient than hunting. So you spend less calories than you used to spend when you were hunting. Industrial revolution brought about even more dramatic changes. And we are yet to see the full impact of the IT revolution. Anyway, modern humans, as well as dental surgeons and all of us, spend less calories during our day-to-day work as well as during work, our professional work. Despite all that, what are we exposed to? We are exposed to calorie dense, more palatable, more refined food stuff. So if we are not very careful, we are very likely to get obese. We are very likely to get an overdose of these unnecessary nutrients, fat, the sugar, and the other lipids. And this is the basis for diabetes, hypertension, hyperlipidemia, and the hypertension. So all these are very important risk factors, for the erectile dysfunction. Other thing is the stress. It's very difficult to quantify stress, but many studies have shown that stress is a significant contributor for all these modifiable risk factors, as well as directly for the sexual function. And the sleep is also important. Do we have liquor after the event? That's fine. The moderate drinking, we found we did a study, and we found that moderate drinking could even be beneficial, but we didn't publish this because it can be misinterpreted, and and also the addiction is a bigger risk than the potential benefit. So the alcohol abuse is detrimental for erectile function. It has two effects. One is the acute effect. Acute effect is that soon after the heavy dose of alcohol, there is increase of desire and reduction in sexual performance. This again was explained by William Shakespeare 500 years ago. And the long-term effect is that you can get testicular atrophy and reduction in testosterone production, and can have long-term negative consequences of hypogonadism or low testosterone. This is self-explanatory. The smoking can cause erectile dysfunction. So I thought I should cover another important aspect of erectile dysfunction or the problems with erection. I talked about a few modifiable risk factors, because no point talking about other risk factors and other medical endocrinological conditions. But the other most important thing is the differentiating erectile dysfunction from psychological erectile dysfunction. If you are able to get an erection during night or in the morning when you are asleep, that means your erectile function is intact to a greater extent. And if you are still having problems with having sexual activity, it's more likely to be a psychological erectile dysfunction. But losing a nighttime erection is indication of vasculogenic erectile dysfunction. So that's a very important thing to differentiate. If you're having vasculogenic erectile dysfunction, it's not a very good sign, because if you look at this, again I should warn you, don't get carried away that you should have an erection all the time you are sleeping, right? Or the wives can touch and feel, oh my husband is having a heart problem because he's not getting an erection in the night. This is like, once in a way, even once a week, if you get an erection, that's fine, right? Once a week even is enough, because you don't, most of the time you don't know whether you have had an erection. This is a very interesting thing to understand. You can see, do you have a pointer? It's okay. This is the bigger vessel is a coronary vessel, or the vessel in the heart, and the smaller vessels are the penile arteries. When there's atherosclerosis, the plaque get deposited in all these arteries. But when they get deposited in smaller arteries, relative reduction in the lumen size is greater than the bigger arteries. All of you can figure that out, work that out. So the penile arteries become symptomatic before they become before the coronary artery becomes symptomatic, right? So but it's not true for other forms of erectile dysfunction. It's only true for vasculogenic erectile dysfunction, because you can get erectile dysfunction for other conditions, and then you will have the nocturnal erections. You can figure that out. The recognition of ED as a warning sign of silent vascular disease has led to the concept that man with ED with no cardiac symptoms is a cardiac or vascular patient until proven otherwise. So it's very important to remember that. I don't know whether I should go in detail in this slide, but I think I should. Interrupt me if you don't understand anything. When there is a person with problems with erection, we have to get a medical history, sexual history, sometimes they need a physical examination, not sometimes, often they need a physical examinations, and often they need investigations as well. The psychological issues are very common. I should share a story because I met this couple yesterday, not as patients, but as in another social event, and I had seen them as a couple with a problem, and they said that that lady dragged me to a side and told me, "Doctor, you should tell this story to the other patients, and whenever you give a talk, because but don't tell our names." She did not tell that I will never divulge patient information. Anyway, since she told me that I should share this story, I'm sharing this story because I think it's relevant. This man is 74, and this lady is 18 years younger, and they had they had difficulties in having sexual activity, and they were the man was very upset because this lady, his wife, is relatively young, and she's very attractive, and she's outgoing, and he was feeling very insecure, and the woman anyway thought that he's he's trying, and first initially he tried and he couldn't, and then he gave up because he didn't want to be a failure in front of her. And then she thought that he's not interested, and they had some conflicts, and they had regular arguments. She was complaining him, he was complaining her that she's not supportive, and she's not. She was saying that he doesn't love her anymore. He doesn't come to her often. So all sort of things, and this created a lot of anxiety in him, and he had gone to several doctors and was prescribed with many medication, and without any improvement in the condition, because he went alone, and he was given all sort of medication. And when I saw him, I asked him whether I could see both of them as a couple, and the lady, the wife, initially refused because I knew them personally as well, but with a lot of reluctance they came, and we spent little time discussing this. It's not magic. It's what we are trained in is this psychosexual medicine is very passive. You don't instruct, do this like that. It's just share your feelings, let them express their thoughts, and give comments, and slowly guide them in the right direction, and the change has to happen within themselves. I'm not instructing to change, but they are changing. So she said 2 days ago also we had very good sex, and now he's perfect. So what I'm trying to say is this mind is the most important sexual organ. So most of these men and women need as a couple some psychological or psychosexual counseling. The cardiac symptoms. It's a tricky thing. If you are to have sexual activity, because some people think that having a heart problem is a contraindication for sexual activity, which is not true, right? You can have a heart problem, you can still have sexual activity, but there are certain precautions that you have to take. Firstly, if you can tolerate exercise, then you'll ask what sort of exercise. If you are to have sex with your sexual partner, your long-term sexual partner or wife, it's equivalent to usually 2 to 3 METs if you quantify the workload. 2 to 3 METs is like equivalent to climbing 2 flights of stairs up and down briskly without any cardiac symptoms. 2 METs is that, climbing up and down 2 flights of stairs, or walking 1 mile in 20 minutes. So if you are even if you are a cardiac patient, if you can tolerate that sort of exercise, you are okay to have sexual activity with your standard or the usual sexual partner. But the problem happens when you play outside, right? Because when you play outside, you are in an unfamiliar setting. You are after a heavy dose of alcohol. You are with an unfamiliar partner. You are very likely to be much younger as well, right? So it can be dangerous, because that situation, more than the sexual activity, other the things precipitate heart attack. It's very important after 40 to exclude low testosterone, because after 40, every year our testosterone levels, that's the male sex hormone, decline by 1%. That decline is acceptable, but sometimes it declines faster. So that needs to be investigated and corrected. This is a rare condition, Peyronie's disease. It's a plaque formation, like penis. The symptom is like penis bent to a side, and it becomes painful when you get the erection, and you can feel a hard nodule in the penis. That's Peyronie's disease. Such patients need the surgical intervention, and it's very important to discuss what the couple expect, because I had another man. He was very happy with the outcome of his treatment, but he came and said, everything is fine with my wife, but the problem is, doctor, like I don't get an erection when I rub against a woman in the bus, because now he's taking a tablet when he has the sexual activity with the partner. So like the patient's expectation sometimes difficult to meet all the time, but we have to try. So the management, in the management, we look at optimizing blood sugar control. It's very important. Blood sugar is a major cause of sexual problems, erectile dysfunction, and the lifestyle modification, which I discussed before. And it's very important to optimize the comorbid risk factors. And the modification of the drugs are very important, because after 40, most of us are on medication for hypertension, hyperlipidemia, and all sort of things. And these medications can have effects on sexual activity, especially the drugs like thiazide diuretics, beta blockers. And the first line treatment for the erectile dysfunction is PDE5 inhibitor therapy. These include sildenafil, tadalafil, and vardenafil. And those who do not respond to initial treatment usually respond better after optimizing their oral therapy. And those who are contraindicated to PDE5 inhibitors can be given transurethral alprostadil, intracavernosal injections, or vacuum constriction devices. And the penile implant is the last resort, but not really the last resort. I thought this is the last resort. If everything does not work, you can try this the snake charmer. We call it Nai Natavanna, but you can call it Nai Patavanna also. Right? What's the time? Do I have time to cover a female aspect as well? Or how many minutes more? 10 minutes, okay. Right, let's look at main female sexual problems after 40. I think even dental surgeons know that the commonest problem is low desire. I think even the ordinary men and women, the general public knows that. When it is very low, we call it hypoactive sexual desire disorder. And often when you see low desire, it's not exactly low desire, it's libido or desire discrepancy, right, which I will discuss in a little while. And difficulty in arousal. Arousal is different to desire. Arousal is when you initiate sexual activity, the vaginal swelling response and the lubrication response. If that is not working, there is that's called female sexual arousal disorder. Third one is the problems with orgasm. Often what happens with the maturity or older age, midlife or beyond, is that not exactly the frequency of orgasm, it's mostly the intensity of orgasm that is affected. Then the sexual pain problems, these are very common due to sometimes due to lack of arousal, sometimes due to other problems, the hormonal changes associated with menopause. Vaginismus is primary vaginismus is not common in this age. It's usually in younger groups. Since it's the commonest sexual problem, I thought I should discuss a bit more detail in 5 minutes about the hypoactive sexual desire disorder or low sexual desire. It's considered persistently or recurrently deficient sexual fantasies and desire for sexual activity that causes distress and interpersonal difficulty. If you have low desire, and if you are happy, and if your partner is happy, then it's not a problem, right? But if it causes distress either in the in herself or in the partner, then it's a problem. But as I said, most often when I inquire the details, often it's the discrepancy. Sometimes it's actually the man is having excessive desire, and he's complaining that the woman is not having enough desire. Sometimes when you have sexual activity without desire, it becomes unsatisfactory. Then it gives no reason for them to have it again, because the one they had was unsatisfactory. Let's look at the common causes. The commonest cause in female sexual dysfunction, especially in this desire disorder, is psychological and relationship issues. Sexual inhibition. The inhibition can happen in many ways. It could be the relationship factors. It could be social factors. What you believe. Sometimes women tend to think that they are not expected to have sex when they reach 40 or 50, or when they have children, or when they have grandchildren. All sort of these concepts and myths can contribute to the inhibition. And as I said, intra and interpersonal issues can contribute. Medical causes are important. Estrogen deficiency is the commonest, but testosterone, estrogen is not the hormone that drives sexual desire in females. As in men, it's testosterone. So testosterone deficiency is important. Hyperprolactinemia can cause the low sexual desire. Both hyper and hypothyroidism can cause sexual desire disorder. Diabetes is a very common condition causing sexual desire disorder. Depression, medication, antidepressants, and antipsychotics can cause erectile dysfunction. The sexual desire disorder. Surgery, the oophorectomy and the hysterectomy can contribute. I think you might not be interested in the assessment of hypoactive sexual desire disorder, but I will briefly discuss the treatment, because I would like to take few questions and finish this session in a minute. Mainstay of treatment is psychosexual counseling and sex therapy as a couple. We always encourage couple to come for the sessions, but sometimes it's not possible. And relationship counseling, often the women's sexual desire is very different to men's sexual desire. They need more care, more love, more attention during the rest of the day than during the bed. So correcting these things are very important, and correcting other medical conditions and medications contributing to this is important. And the one important thing I should emphasize to you is the partner sexual problem. I have seen many women losing sexual desire because the man has sexual problems, especially premature ejaculation. They ejaculate as soon as they penetrate, and it causes a lot of distress to the partner. Sometimes women don't express this dissatisfaction, and but they just lose the interest because it becomes very unsatisfactory. And sometimes the sexual technique, the way they have sexual activity, and not giving the partner enough opportunity to express herself. So sometimes actually the men are also responsible for the loss of desire in the female. So let me finish with a thank you. Thank you very much for patient listening, and I'm very happy to take questions, and I think if you have time. No questions? I know you don't want to let me go without somebody asking a question.